Well, I want to thank everyone for coming tonight to Wu University's presentation, Clinical Pearls in Retinal Disease Management by Dr. Paul Karpecki. I'll be your host, Dr. Carolyn Major. And a special shout out and thank you to our exhibitor and sponsor, Eye Care, for this event. We could not provide free CE without their support, so a very special thank you to Eye Care. And a few reminders before we get started. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. And for a COPE certificate, you need to fill out the survey link in the chat. And also at the very end of the webinar, there'll be a pop-up that will take you to the survey at the end of the presentation. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the very end of the presentation. So if you have your OE tracker app, you can't just use the regular camera on your phone. It has to be the OE tracker app. You can capture that QR code to get credit as well. CE certificates will be emailed within 4 weeks, and we will have a live Q&A at the very end of this presentation. So please put in your questions for that Q&A session. You can ask questions by using the Q&A at the bottom of the Zoom floating panel. And if you're attending through your phone, you can also submit questions by putting them either in the chat using those three little dots in the bottom right-hand corner, or you can click on the Q&A and submit your questions that way as well. So without further ado, although I don't think he needs an introduction or me to read his bio because he's so well known, let me allow us to introduce Dr. Paul Karpecki. So Dr. Karpecki received his Doctor of Optometry degree from Indiana University and completed a fellowship in medical cornea in Kansas City in affiliation with the Pennsylvania College of Optometry. He currently serves as a director of cornea and external disease for the Kentucky Eye Institute in Lexington, Kentucky. He served in the TFOS DEWS 2 Diagnostic Methodology Subcommittee and DEWS 3 Treatment Subcommittee, as well as co-chaired the previous 2 and upcoming TFOS symposia. Dr. Karpecki is an associate professor at the Kentucky College of Optometry, teaching at the University of Pikeville. So without further ado, I'll pass it on over to you, Dr. Karpecki.
Thank you, Dr. Major. What a great introduction. I appreciate that. Thank you to Wu University for this opportunity. They always do such a great job. And for all those in attendance, these are my financial disclosures, companies that I do research with, advisory board, speakers bureau. It's interesting. I look back at this bio and I realized, I didn't put my retina stuff in. And here I am doing a retina course. I completed a 2-year retina preceptorship. So that was it's interesting. My first love was actually retina. I did a residency at the Lexington, Kentucky VA back in the mid 90s, kind of to date myself there. And that was my first starting. It was an incredible year. I loved it. And then this cornea fellowship opened up and the rest kind of history, but I never lost the enjoyment of the retina side of things. So when COVID hit and I wasn't traveling as much, there was this preceptorship at Retina Associates of Kentucky, a top 20 retina practice in the United States. I think they were looking to bring in someone younger. But I talked to the guy, I'm like, hey, I've got an extra day a week if that'll work. So I spent almost 2 years doing that. It was one of the greatest experiences of learning and bringing things back. And then I stayed on staff. And then now I'm only running my cornea clinic, but that's my retina background. So I'm going to take you through some retina stuff, which I love getting to do. It's still a big part of my practice. I'd say I do more uveitis, which is kind of related, but I still see a lot of retina, but not specifically them coming in to me for that. So I decided we would just do a bunch of cases that would be fairly straightforward. You're not going to get the retina insights you might get from a Dr. Carolyn Major, someone who's one of the tops in the country in this field. You're going to get a guy who worked in a top 20 retina practice for 2 years after a preceptorship, plus all the stuff over those years seeing. So you're going to get much more practical lecture in the sense of I'm like you guys when it comes to retina. Some of you on the call might be more advanced than me even in retina, but you're going to get more of that general perspective. So we're going to start with this 36-year-old gentleman coming in. His husband's actually a staff member, so I thought this would be a great case to do. He regularly sees an ophthalmologist. And I'm not trying to put down ophthalmology when there's a case that ophthalmology got that did miss something and then it came to us. It just happened to be the case. So it's just being legitimate and honest. And I think it's important too, though, that to realize that things get missed by anybody. when you don't have all the best technologies, or maybe you're just used to seeing it. But being a staff member, oftentimes, especially their husband, you're going to look a little more closely. Most recent visit was 2 months ago. He has that history of type 1 diabetes. I'm sure there's some questions you already would ask based on just this little bit of information. And he came in with a chief complaint of large floater affecting vision in the left eye. Because this staff member joined our clinic, she's like, why don't you just come in? It just happened to be one on a Monday. I don't, Monday's not my typical cornea day, but I usually go in, have a staff meeting, and then have some time. So this gentleman, of course, she came over to me and said, hey, my husband's coming in. Do you mind taking a look? He's got a big floater in his left eye that just developed. And I'm like, sure. I started thinking about diabetes. If you think about population numbers, it's pretty huge. 15.8%. Remember that number, the US population, just under 40 million people. I talked about dry eye being important, probably about 38 to 44 million, depending on the study. This is just as large. And what's amazing is it was only 6% at the turn of the century. It sounds like a long time ago. It doesn't seem like it to me now, 2000 to 15.8%. I don't have 2024 data, couldn't find it yet. I'm sure it's out there, which is incredible growth. Look at the down below when you look at the colors, how much we've seen an increase in diabetes in the United States. People are hoping some of the, semaglutide meds that have come out may actually send that back a little bit the other way, but we'll have to wait and see. Let's go back to our case. His vision was pretty good. 2020, 2025, external exam, of course, was clear. I looked for rubeosis, didn't see any sort of blood vessels in the margins. Fundus exam. Let me take a look and show you that. So one of the big advantages of technology, I'm so lucky. When I needed to get a fundus camera, I got a confocal camera. And I think it just helps to see resolution that others may not see in some of these cases. But when he presented, look at the detail this shows. That for me is so valuable. And as you can see, this is certainly a significant diabetic retinopathy. And you wonder, well, this patient was just seen 2 months ago, but you got to wonder if, sometimes if you just do ultra wide field, which I believe is what I asked him, what did they do then? There, he said they just did one. It had some greenish images. Said, oh, I know that one. He said they took took pictures every time I've been in. He said, but I didn't see any floaters then. This was just kind of new. So I looked at this picture and I recognized a lot of things. One, I've got exudates in an awful lot of areas, dot and blot hemes in all 4 quadrants. That becomes important for me in my management. And then I start looking closely and I'm seeing these, little blood vessels forming in a number of places. Some neovascularization, at least in 2 spots. And of course, what type of hemorrhage is this patient having? And this is an important question because a vitreous hemorrhage is obviously a little more of an emergency of getting them to a retina specialist. A pre-retinal hemorrhage, on the other hand, I still get them to a retina specialist, but not so urgently. It's not immediate. With a vitreous hemorrhage, you got to risk all kinds of things can happen, can lead to obviously significant loss, can lead to eventually some scarring, some traction. Pre-retinal, which I believe this is, because remember the definition of a pre-retinal hemorrhage? You have this boat-like hemorrhage that's there. Let's zoom in on it a little bit more to see the neovascularization areas it may have come from, where are the areas involved, the exudates, all of it's involved. And I can see why he sees this now, even though his macula is spared. So maybe that's why he's only 20/25. Okay, so vitreous hemorrhages versus pre-retinal hemorrhages. Vitreous refer to bleeding, obviously, into the vitreous cavity, much more serious area to have involvement when it comes to proliferation. Pre-retinal hemorrhages are really that little zone in between the retina and the vitreous itself, the gel. If you think about a, kind of more of a PVD or something, that's your vitreous pulling forward. It's that little area between. If you think a little bit more of the vitreous itself, as in a vitreous hemorrhage, it's obviously right within it. So pre-retinal, I always remember this being the boat-shaped lesion. Vitreous hemorrhages warrants immediate referral. Some experts say within 48 hours. Pre-retinal hemorrhages, you've got a little more time. I still think because of the neovascularization I was seeing and all the other findings, I would still get the patient in 2 to 4 weeks. But vitreous hemorrhage, probably within 48 hours. So vitreous hemorrhage. Here we have a vitreous hemorrhage. Doesn't look like a boat. It's definitely in that anterior area. It's a little more serious, more neovascularization. This is a high-risk PDR presentation. So differentiating them will help you a lot, even though we're going to send both off to a subspecialist. These are different. So we are looking at the other eye. You're definitely also seeing significant amounts of neovascularization and certain, not significant amounts, I shouldn't say that. Areas of neovascularization are present within that. I'd certainly want to take a look at an angiography and other things to help determine all of what's involved. But you can definitely see it present. And again, sometimes when you're kind of an average doc when it comes to retina like I am, having good technology makes a huge difference. I may not have seen this as well by looking in the back of the eye. I may not have seen it with other imaging systems. I had no problem seeing it with confocal, my imaging of the retina. When I'm seeing a lot more than I ever see otherwise, as we see there, the blood vessels. All right. So I asked the previous exam. He said he doesn't recall. I told you this already, being dilated, but he had a picture taken of his retina. Yeah, he said he had eyelashes in the picture. He was hard for him to see, even though he wanted it because his wife works in the field. He was told that there were no significant changes in retina, but to continue monitoring his eyes yearly. And I don't fault the docs. This was just a case, I think, of not dilating that time, relying on imaging, busy practice that he came from. But that's why it's so important for us to get good measurements, to look carefully, to dilate, to really kind of assess where the patient is at and trying to make it easy. So here's some things that I would have loved to have known or seen from the previous chart that were not there. And he was good enough to bring in his notes from the previous chart, previous exam 2 months prior. How long have you had diabetes? What other questions might you ask? Do you know your A1C? Asking about the A1C is two really valuable things. Number one, it helps me to know, that the patients are monitoring it. And number two, I want to know if it's abnormal. If it's a 9, obviously I'm going to be a little bit more aggressive in follow-up and make sure he sees his PCP or endocrinologist. Blood pressure. Why is blood pressure important? Well, the combination of hypertension with diabetes actually apparently appears to accelerate things. Do you smoke? His blood pressure was measured at 145/94, a little elevated as well. He was a young patient, remember that. So DME risk factors to take a look at. And this was from a lecture I did with Paul Chouse. So I might give him credits because I think we put these, had been his slides or I added stuff or vice versa. But major risk factors are the severity of the diabetes, diabetic retinopathy. How many quadrants are involved? You want to keep it simplistic like it would be for a retina doc of my level, meaning I'm not known as a retina doc like Carolyn and others. So I look to see if I've got retinopathy in all 4 quadrants. I look to see if there's neovascularization. I look for urgent, serious things like retinal detachment with traction or vitreous hemorrhage, which we covered. You also want to know duration, 5 years versus 20 years. Hyperglycemia, hypertension, we went over that, dyslipidemia, and even pregnancy, which could exacerbate it. Other potential risk factors out there include sleep apnea, if you really want to delve into questions, diabetic nephropathy, glitazone usage has shown some potential risk factors for acceleration and even, of course, anemia. So a lot of new insights have come in. So next steps, I think we're okay in not making this an emergency, but not sure. I've had these all the time. When I worked in retina for the years I did, I would often get the calls from colleagues who would say, hey, should I send this in now? Or when do you want me to send this patient in? And that's a great way to do it also. You can call the practice and say, hey, or call the retina specialist. They're phenomenal for that, especially ones I've worked with for treatment. They would probably tell you, yeah, I'm okay in 2 weeks with this one. I'm going to be fine. Now, vitreous hemorrhage, I think they'd want to see it much sooner. PRP is going to be required. The heme will resolve on its own. I educated him about that. And I went ahead and set him up with an appointment for his PCP because I didn't like the fact that he had hypertension with no medications to go along with his diabetes. All right. So when do we refer a patient to a retina specialist? I think there are a few times that come to mind, at least in my way of doing it. I'm still working with that group in my own practice today, though. Moderate, severe, non-proliferative, I think, are good ways to go. And that really just depends on your level of comfort. Some people look for IRMAs, intraretinal macular aneurysms, macroaneurysm, sorry. Some people, decide that it's just, hey, all 4 quadrants. I like that one. That one's more my league. DME with visual acuity that's less than 20/30, I think is a good one to send. Sometimes some docs will say, hey, send it at any point, which is perfectly fine, especially if you have an OCT. But these are some nice guidelines. And certainly, when we come to Q&A at the end, I'm glad to have Dr. Major on this one. She can even add in her own what she looks for because she's in the retina practice getting these patients. But here's what normal looks like. You can see the This other patient we just saw earlier, the staff member's husband had these prevalent also. I think the one in the upper right's a little better to see than the others. But these are good examples of maybe that, moderate non-proliferative diabetic retinopathy to even severe non-proliferative. And that's a good stage to consider sending the patient in. Most good retina doctors are not going to mind when you send them in. But as I've always told my colleagues, hey, 4 quadrants, go right ahead and send it like that. That's enough for me to say, hey, let us figure out if they're ERMAs if you don't want to. Let us use the imaging to figure out what the perfusion levels are. We've got exudates near the macula. There could be some DME there. Go ahead and send that in. But if the end, 4 quadrants is good enough reason to send a patient in. And most retina docs would be great about that. Peripheral lesions, what's the importance of have that factor? This one might be important. Well, there is some research that shows that patients primarily have peripheral diabetic retinopathy and less in the posterior actually elevate their significant risk of diabetic retinopathy progression or worsening by 3 to 5 times. Study by Silva showed that. So that's why I always like the rule, hey, if all 4 quadrants are involved, meaning you've got some peripheral lesions, go right ahead and send that. That's a good group of patients to consider. You don't have to be an absolute expert in ERMAs versus neovascularization. I think this is a good time that most retina docs would be thrilled to have that patient. Here are the stages, though, just as a whole. You obviously have non-diabetic retinopathy mild. We are seeing some exudates near the macula, so I certainly want to get an OCT there. Moderate diabetic retinopathy, where we could see some of the ERMAs we described, and then severe, where we're worried about potential for traction, RD, other factors play a role. But the hallmark there is going to be neovascularization, which we showed some good examples earlier, but all 4 quadrants, as we've emphasized. I also think OCT is so valuable just from the DME standpoint. Whenever you see any lesions or exudates near that macula, I think, why not? Let's get an image of that patient. It warrants it. They do have diabetes. Let's see if there's any early stages, because many patients will walk around with 20/25, 20/20 for a long period of time without it being a factor. And sometimes it tips. And so we want to be checking it with OCT. So the current standard of care, if you do see diabetic macular edema that's center involved, is to do what treatment? You might see this question. It's anti-VEGF injections. That's standard care, especially if vision's 20/30 or worse. And people debate the level. Why wouldn't you treat at 20/25? And some people, if someone's a pilot or doing something more significant for visual tasks, absolutely, that'd be a good candidate that's under 20/30. But this is a good general rule for the vast majority of patients. And with anti-VEGF injections so readily available, it's well worth referring that patient. There's an example of a patient who has much worse than 20/30 vision from DME. This is after 1 injection. I know that doesn't happen all that often. It's one of my patients way back when. But nevertheless, you can see amazing responses. And imaging will tell you so much of what's going on. But even looking for exudates, within that zone of the macula is well worth getting an OCT. Just like our patient today, who is the husband of one of my staff members, and I'm seeing a lot of exudated material very close to the macula, seeing neovascularization fronts. I definitely want to get an OCT on him, and here's what his imaging looked like. It was certainly present, even though his vision was surprisingly under 20/30. There's the other eye. All right, so good little guideline of when to refer. So DME, 2 to 4 weeks is a good guideline. Now, every retina specialist might be different. This is kind of what my group that I used to be part of would have looked at. And this is what I spent a lot of time teaching to my colleagues around here. I didn't do a ton of national speaking in this area like I do with dry eye and other things. I left that to the true experts like Carolyn. But when I was teaching colleagues in my area saying, okay, when do you want to send a patient? I kind of went to this graph. Severe or very severe non-proliferative diabetic retinopathy, I'm going to probably recommend that same time frame, unless you happen to see high-risk findings. And high-risk findings involve traction or retinal detachment, or the vitreous hemorrhage we talked about at the beginning. Even proliferative diabetic retinopathy, we're often saying, within a couple of weeks is fine for most of those patients. The only one that's really where we are saying, okay, get them in soon, is 24 to 48 hours of the high-risk findings I just described. And moderate non-proliferative, that's where you see the beginning of some ERMAs involved. I think your comfort level, but once 4 quadrants have lesions, that might be your recommended time frame. All right. So we talked about when they should be referred. The prompt retina specialist was when it's a vitreous hemorrhage. This patient didn't have a vitreous hemorrhage. They had a pre-retinal boat-shaped hemorrhage. If they had a retinal detachment, a vitreous hemorrhage, or other evidence of advanced severe PDR, probably within 24 to 48 hours. I should say 48, sorry, not 24 to 28. That's pretty tight range. 48 hours is the key. Vitreous hemorrhage, just as a reminder, pre-retinal hemorrhage, very different. Both warrant a retina referral, but different urgency. Tractional RD in a patient with proliferative diabetic retinopathy, that's an emergency. And here's the other eye, unfortunately, both showing it. Here's one of my most impressive pictures of a patient that presented when I worked at Retina Associates of Kentucky with tractional RD at presentation. Here's my gentleman coming back now. So here's his follow-up. It's about 6 weeks out, or two, because he had 2 visits, and now you can definitely see we're resorbing the pre-retinal hemorrhage. But you see the PRP spots down at the bottom, so and at the top left high quadrant, and at the bottom. So he's had some treatment done already for those areas of non-perfusion and potential neovascularization. And we're going to, obviously, they and I are following him much closer. There's PRP again, performed inferiorly, as you can see there. I'm in those zones, and then what they're kind of watching. All right. Case 1 out of 4. That one took a little longer. These next ones will be a little bit more practical, even though it has some practicality to it. It won't be as long. So this was a 73-year-old patient presenting with decreased vision over the last few months. And I decided for today's presentation, I would just take some of the more recent things that showed up into my practice. So, and think of my practice probably very similar to most of yours when it comes to retina. It's just going to be something that if they show up, they do on those days that are non-dry eye, non-cornea. And so this may be one you'll see a lot of too. 2025 OD +2, 2040 in OS. Overall health is good. I like, big difference. The first patient came in, sudden loss of vision, so to speak, or sudden, not loss of vision, sudden floaters, just came out of nowhere. Big, large floater. This patient, gradually over the last few months. Sometimes the time frame can give you a lot of insights as well. All right. Let's see if I can't see the chat. So what's going to have to happen, Carolyn, at the end is you're just going to have to bring up questions that could have been related to the cases, and we'll try and get to them at the end. I'll go fast so we have some time.
Absolutely.
Okay, because I can't reach it for some reason. It won't pop up. Okay, back to our case here. So here we take a look at what we're seeing and exactly what are we seeing. If I were to ask you, you can put it in the chat, but I can't see it. But still, we could tell if you're right at the end. It is in mainly, obviously, in that left eye, trying to show you the macular pattern there, trying to also show you, oh, look at that, it came up. Let me see if I can get to it. Can't. And then we've got obviously some elevation taking place there. Other eye, just for reference, some signs as well. Carolyn, I'm sure you've seen many of these over your years. Let me get you a better example of some here, a little more severe. We could see that very white line on the raster in the horizontal B scan that's sitting on top. And then obviously with the thickness, you're getting a pull there taking place. It's going up, and then just displacing things going lower. And these can certainly lead to a macular hole over time. But at this stage, from the first presentation, this is not that patient. First presentation is here. You can definitely see that what's present. And that's, of course, an epiretinal membrane. Good job. This comes up a lot, though. What do we do with epiretinal membranes? When do we send them? When do we have to take a look at them? Here's a more typical example. And I tried to use different maps because when I was at RAK, we had 3 different OCTs. So I can show non-bias, put them all in here. But this one here, you're seeing that very nice line on the top of an epiretinal membrane. Kind of shows up also in terms of the thickness map, the macula, and gives you a pretty good example. This is probably a patient who's seeing quite well, actually. This patient probably not seeing well at all. So it just gives you an idea of the level we can be there. So epiretinal management, epiretinal membranes come up a lot in optometric practice. That's why this would be something that show up in mine. Typically, I monitor these until they become visually significant, either by my standards, like a 20/40 or worse, or by the patient who sometimes says, I can't function, then that becomes my time to consider referring for potential treatment. And obviously, if there's actually leading to a potential issue later on, their vision is going to be affected. But most of these just watch. They just kind of slowly don't change much over time. And you just dilate, examine. But the very first thing when you get one is to make sure that it is just one of those slow developing epiretinal membranes. And the reason we say don't worry about it, sounds strange, is that a lot of the success is pretty similar, whether it's a 2025 epiretinal membrane or a 2060 epiretinal membrane as far as after surgery. So it's not an emergency in the sense that we're going to get this huge hole that we're never going to repair. If it is, they're probably already pretty far in advanced in their vision, so you're going to send them in. But you got to make sure it is one of those slow developing ones, because otherwise it could be caused by a potential retinal hole or a tear shoe or a horseshoe tear. And then that's important, because if you're missing that, that's of high risk also for retinal detachment. And I've seen those that, suddenly came on, looked under the OCT like an epiretinal membrane, but sure enough, there was a big horseshoe tear in the far periphery. And that, was leading to it. And that's why dilating, and that sounds odd. Why am I dilating? It's right in the macula. I've already got my OCT. Well, you got to be suspicious of a potential retinal hole or horseshoe tear that could be present. Treatment for these, believe it or not, typically triamcinolone injection in early stages, and then surgery if there's significant vision loss to repair that. All right. This is a patient was treated with just triamcinolone injection. This is kind of, I think, before the treatment ahead of time. You see really nice response. I should have showed you before, but definitely vision restored back to about 20/25 in this patient. And that was all that they ended up having and necessary for it. And they're seeing some decrease in the thickening that's in place there from where it previously was. So epiretinal membrane, main pearls to this one. It is one you can monitor. It's not one that you have to fear or worry about getting in right away. There is a time point, though, where either the patient's really affected by vision or you feel like it's 20/40 or worse, that we often think, okay, time to send over. Always dilate on epiretinal membranes, just in case there's related to the development of it is because of a previous hole that's there or tear. And so those become important to monitor, and then educate patients. And I like to, after a good, thorough fundus examination, you have a little time to bring these back. It's not maybe 6 months the first time, just to kind of monitor and see how they are, or every time on a regular basis about that time frame. But it's not one you need to see back soon. All right, let's hit case 3. Now, this is in my world. I get these a fair amount. I shouldn't say Sjogren's syndrome, a lot. I have over 500 positive diagnosed Sjogren's syndrome patients in my clinic for dry eye. And a lot of them are going to be on which medication? You probably already figured the retina association here. They're going to be on Plaquenil. That's exactly right. So this patient presents with decreased vision, but amazingly, she did not show the typical patchy corneal staining that we often see with Sjogren's syndrome patients. Sjogren's syndrome patients are really cool. Any autoimmune dry eye is really cool to diagnose, because there was a study. And here we bring in, man, he can't even keep his dry eye stuff out of retina. He's bringing dry eye into this back of the eye course. And you're right, I can't. There was a study done by Barbara McCaffrey, famous OD, was president of the Academy, other things like that, many years. But she did a study that showed that it's almost 100%, like 99% of all patients who have non-autoimmune dry eye get more corneal conjunctival staining in the nasal part of the eye than in the temporal, or equal. And if you do a lot of dry eye, you will see nasal does tend to have more generally, or they're equal between the nasal conjunctiva and the temporal conjunctiva when you put your sodium fluorescein in, except for autoimmune patients. 93% of them had more staining in the temporal conjunctiva than the nasal. You think that seems too easy. How could it be that extreme? Well, the way I figure, and this has not been scientifically proven, but most patients who have inflammatory non-autoimmune related dry eye disease, like non-Sjogren's, like KCS, the inflammatory cells migrate to the puncta, and you tend to get more staining in the nasal part. Sjogren's syndrome patients have inflammatory migration and proliferation of the yeah, you get it, the lacrimal glands. And the lacrimal glands are over here temporally. That's where the inflammation is. And so it drifts downward temporally. At least that's my theory, even though I didn't do the study and it didn't say why it was. I believe that's the reason, or at least it's a good way to remember it. So this patient originally presented with more temporal staining than nasal. And that's when I go ahead and say, okay, this could be an autoimmune form, more likely to be Sjogren's, especially if they have patchy corneal staining and a thin tear height, thin tear meniscus. Let's go ahead and get that checked. So anyways, this is one of those patients who already came in with a Sjogren's syndrome diagnosis, autoimmune and arthritis. But she didn't have any, she had a big decrease in vision, but I didn't see any change in her cornea or her conjunctival staining. How could this be? Well, she's on Plaquenil, hydroxychloroquine. So we've got to monitor this. And she's been on it for a long time. First question is, has it been more than 5 years? Patient's like, yeah, it's been like 15 years. Second question I always ask is what? What's the dosing? I don't think I've ever seen a bullseye or a toxic maculopathy from Plaquenil in anyone under 200 milligrams. Now, it can happen because it's based on body weight. So if you had a patient who was under 110, 105 pounds, they'd have to be that. On 200, they could actually develop Plaquenil bullseye maculopathy or toxicity. But the 400 is the one that worries me because that's the I've only seen 3 cases of this in my career, maybe 4. That's all ever. And I got 500 patients or more who have Sjogren's syndrome, KCS in my clinic. So it's not a common thing unless, they're just monitoring it. But most important question is how long you've been on it. Second most important question is what's your dosing. But all of my 4 cases, one was a milder one. We got them off. The others were progressive. And the problem is when you stop the Plaquenil, it keeps progressing for a while longer. You can't take it out of the body. It's got to run its half-life, which is pretty long. But the 400 is the one I get worried about. That's the one I'm going to be checking those patients on a regular basis. 200 doesn't mean you can't do your job of Plaquenil testing, but I talked to another retina expert who's managed a number of and referred a number of these. He's an older retina specialist. He said he's probably had only about 10 or 15. He looked back and never found one that was on 200 milligrams. They're all on 400 milligrams. So always remember that from him. So you really want to watch patients who are under 135 pounds, especially on the 400 milligram dosing. Again, it doesn't mean you could, forget the people who are, 150 pounds on 400 milligrams because there's still a lot of factors, but it's a pretty good generalization that seems to apply well for patients who are on it. And we talk usually female. There could be males under that too, don't get me wrong, but that's the common patients I've seen who had Plaquenil toxicity were all female and they were all 120, 125 pounds. And people lose weight with age, so you can see more of it. And how many years have you been on it? All right, standard testing for Plaquenil macular toxicity is a 10-2 visual field. Although there's new research that says you should be doing a 24-2 in the Asian patient population. For some reason, their form of macular toxicity appears to be wider in terms of where you pick it up. And you need to be looking a little further than 10 millimeters. So you're going to be out 24-2. So kind of a neat insight there. Fundus photography. If you have confocal, it really helps to get great imaging coming in, but any fundus photography is probably a good idea. I certainly want an OCT of the macula. And again, people say you don't really need to do your first one until 5 years. Well, you got to have a baseline. So do your first one the moment they're on Plaquenil. And I still like having one somewhere in there. If they're on 400 milligrams, especially, it wouldn't hurt. Educate them about changes that take place. But those are your 3 kind of standard tests. You got to do a baseline, and then after 5 years is considered the more standard approach. It wouldn't hurt if you did it sooner. There's no problem with doing it sooner. But after 5 years, for sure, you want to have yearly checks. And I would recommend, as I said earlier, in the higher dosing. Now, if you get some kind of odd testing, didn't kind of line up, maybe there's something going on, I can't really tell. Fundus autofluorescence is helpful. It reveals early damage to the RP as a ring, increased sign. It's actually great for monitoring progression, meaning you get the medication stopped immediately. But if you want to see if it progressed a little, because it tends to do that after you stop the medication, that could be a good way to monitor it, a little better than just looking at the color photography on the eye, at least for progression. Multifocal ERG is helpful, provides objective measures of macular function, can help confirm early retinopathy. There's handheld VPs and ERGs now that are really helpful and really accurate. That could be a great way to kind of check that again. And as we talked about, 24-2 in the Asian patient population is more likely as an idea because they tend to develop a pericentral extramacular pattern of retinopathy that's still permanent and progressive. So it is kind of become a new thing to recommend, relatively new, on the patient population of Asian descent or Asian patients. There's my patient. As I said, she was almost 15 years on it, 14.4, something like that was if I looked at the chart. She was on 400 milligrams. She weighed 125 pounds. She had lost weight over the years, though. She might have been over 135 early on, but she was referred in, and the classic pattern again. This is confocal fundus imaging. You're going to see stuff I can't see other ways unless you got really good talent. But that's why I used to do dilated exam with ultra wide field. Now, I still dilate, but I love the imaging I can get here. Can't miss this bullseye maculopathy. So at that point, it's okay. You can't take any more of your medicine. I need to get a hold of your rheumatologist, let them know what we're finding. Unfortunately, this is not reversible when we stop the medication. And it can actually progress a while over the next 4 to 8 weeks and even longer in some rare cases. So we need to bring you back and kind of monitor where you're at. Maybe fundus autofluorescence comes in handy there. Pretty amazing pictures. How you can't miss the bullseye. For those who may not have seen it, sometimes they're a little more subtle, and this one was obviously very readily noticeable. Since we also mentioned doing an OCT, there's her OCT. Obviously, that unique pattern there being present, involved both eyes, one eye much worse than the other. So key pearls, bullseye maculopathy basically matches. I can't move this, the appearance of a bullseye. It's not reversible. It actually may progress even after medication is discontinued. High depends on dose, duration, and the weight of the patients. You get a little insight if you're following patients on this medication as to, hey, 200 or 400 milligram dosing. That's really important. Watch those 400. Don't dismiss the 200, but talking to a lot of experts, it's pretty rare to see this with 200 milligram dosing. 400, that's more serious to watch. Duration, this patient was only 14 years. That's still a long time, but usually think longer. And patient weight at 125. Okay. I should start taking questions, but we're going to do them at the end. And I'm going to, like I said, get finished 5 minutes earlier, or 10 so we can get through. Let me do one more case so we can go through Q&A. Sometimes Q&A has the best education compared to listening to a doc speak. So 63-year-old female, African-American female this time. She's had type 2 diabetes for about 8 years in her history. Hypertension, again, remember we talked about the importance of knowing those two, maybe taking blood pressure in the office if you have the ability to do that. But those two can accelerate each other. They tend to commonly happen together too. All right, states her A1C is 6, which is well controlled. Blood pressure, we tested it twice that day. She said normally it's lower. She says usually it's somewhere around 1, close to normal, 130, even though she's on medications, and normally around 85 to 90. So could have been white coat syndrome. We're testing her. She's in an office here, a new office, cataract grade 2, best corrected vision 20/25 plus. Seems pretty normal. Seems like not a lot is going on there. So we went ahead though, and after looking at her, fundus photography was taken for annual monitoring of her diabetic retinopathy, as would typically be done. And surprisingly, we didn't find any diabetic retinopathy, but maybe the hypertension was playing a role. We found this one little lesion at a bifurcation right there. Typically, they show up brighter, but one of the great things about this type of imaging is everything shows up and could be a little different than you've seen with others, but you can't miss them if you look closely at where it's at. There's a little better way of picking it up. So yeah, this was, if you hadn't guessed it, Hollenhorst plaque. Interestingly enough, it was right at the bifurcation, which is a common region we're going to see it. What is it made up of? It's an emboli basically caused by cholesterol plaque that's been thrown off. And where's it being thrown off from? That's probably a better question because there's probably more testing beyond the eyes, more systemic involvement, because she didn't even notice anything in her eyes. She happened to be coming in for her annual diabetic retinopathy testing. This would have been a Monday patient. I don't typically see these any other days. I kind of got residents and fellows who probably see these, and I'm able to kind of be available. It's an emboli caused by cholesterol plaques. As we talked about, most commonly secondary to carotid artery obstruction. So she was sent for that bilateral carotid duplex testing with her PCP or cardiologist. Turned out to be her PCP. And what the worry here is, from an ocular standpoint, is it's not that that's free either. Even though I'm worried about her getting a stroke or emboli in lungs or other things playing a role, the eyes are not immune either. There's always a chance of a central retinal artery occlusion that can occur. So some key pearls on this, because the biggest risk is actually not in the eyes. It's a cerebrovascular accident or stroke is what we're worried about. The patient had over 85% obstruction of her right carotid artery. Better diagnostic technologies are essential to observing findings such as this when they're subtle. And I think it likely be missed by traditional non-confocal, non-true color imaging of wide field. And that's why new technology is so valuable to have. A top retina doc that does a lot of this probably is going to do fine. Someone like me who does retina on the side now after being in a major retina practice for a while, now just in my own clinic for it, once in a while, I'm going to need all the help I can get. So for me, I don't know if I'd have diagnosed it without that. So optometry's role in retinal disease management is the quarterback. We are the ones who've got to know when to send, when to pass, when to punt, when to keep them, when to keep the hand off, all of that stuff in managing patients with retinal disease. And that was the coolest thing, because when I worked in a retina practice, it was the excellent referrals that we always stood out. The doc who's like, I know when to manage it. Once all four quadrants are involved with diabetic retinopathy, I send them. And that's perfect. It's early enough, usually. You're going to be in a good spot. You're going to know what to do. You're going to really know when to hang on to the epiretinal membrane, because that's not one I'm too concerned about serious issues if they're 2020, 2025, even 2030. And typically, a lot of surgeons aren't going to do much with them until they're 2040 or worse. So it's that knowing when to hang on to, when to send. Knowing a vitreous hemorrhage is an emergency, a pre-retinal hemorrhage, still going to see the retina doc in the next 2 weeks, perhaps, but I can let that resorb. It's that type of quarterbacking that's so critical, that makes our profession really stand out, especially in diabetic retinopathy and DME. We talked about there are cases you might have a DME because it's a simple anti-VEGF injection as standard of care where the patient is 20/25, but most patients we tend to see around the 20/30 or worse timeframe from a coverage perspective, from a visual difference perspective. But that's, again, not one that's arguable. Some docs really believe the sooner you do it, the less long-term issues as you bring the macula back to being flat. Others are like, yeah, when they're having trouble or they're worse than 20/30, then let us consider it, because we're typically not going to do much surgery under 20/40. So that's where communication with your retina specialist is so valuable for the ERMs. Best profession for monitoring, obviously, Plaquenil, hydroxychloroquine is going to be in patients with autoimmune disease, going to be our profession. When I worked in a retina practice, that's not something that worked well for that practice. It's kind of like we probably don't even break even seeing those. Now, if you suspect vision loss, you suspect bullseye maculopathy, by all means, call the PCP, get them off their medication, get the retina doc involved. But for monitoring, that's optometry's wheelhouse. Remember those 3 tests we did, the 10-2 visual field, I think, color photography, OCT. You can do a few more things beyond that, but that's really a great way to kind of monitor these patients regularly. And in the case of the Hollenhorst plaque. We're often the first to diagnose these patients, and now we're saving lives, just not vision, because their biggest risk, of course, in that patient with 85, 86% blockage was the CVA. So these are some general insights. It's not your most in-depth retina lecture you've ever had, obviously, but I think there's a few little pearls, and sometimes it's just great hearing from kind of that perspective, that stuff we see on a regular basis, what to do with it, how to manage it, and what to do from there.